Everyone, it's Ajanette and I am here to cover your schizophrenia spectrum disorder lecture. This is referenced as a spectrum disorder because not every patient or client presents in the same way. So there's a range of symptoms and patients and clients can experience those symptoms differently. They might have some symptoms and not others. They might have a range of severity in the symptoms they experience. And there are different schizophrenia-related disorders that we will learn about in this chapter that sometimes represent kind of the stage or sequence in which the disorder is progressing, or different degrees of severity, which we'll talk about as well. So let's dive in. As we're learning about the symptoms of schizophrenia spectrum disorders, you're going to hear about positive symptoms, negative symptoms, and then there's also cognitive symptoms as well. Positive symptoms are symptoms where you see something added, some behavioral pattern or sensory experience that's added to our normal functioning, right? And so these are typically exaggerated and sometimes very negative and kind of scary symptoms as well. They can include delusional thinking, where we're not in touch with reality. They can include hallucinations, where we have added sensory experiences like hearing voices, or visions, or even tactile experiences, tastes or smells that aren't related to an actual stimuli, but rather something that's being produced neurologically. Brain scans can actually show that our brain areas do light up. So when we're having auditory hallucinations, we have brain areas that light up that would be consistent with actually hearing those voices. You can also have disorganized thinking, which is often visible and observed through our speech patterns, where it's not making sense. It's very illogical. It can be the tone, the pace, and the content of what we're saying. And then we can also have abnormalities in our movements. So they can be very disorganized and abnormal movements, whether it be tics, whether it be engaging in behaviors that aren't aligning with not just the situation, but they can even be perceived as erratic. Potentially some might misinterpret it as dangerous, and we will talk about some of the risk factors or the types of schizophrenia that might pose the greatest harm to yourself or others. Negative symptoms is when you kind of see the removal or the absence of behaviors that we would expect to be there, whether it be speech, whether it be movement, and so we'll talk about some negative symptoms as well. And then one of the most prominent symptoms is the psychosis itself, and the actual disconnect with reality. And that in and of itself quite often might trigger added inquiry about schizophrenia symptoms. So when we see someone that is disconnected from reality, our first thought is psychosis. Is this schizophrenia? You can have psychosis with severe depression, with severe mania, and depending upon the severity and the persistence of that psychosis would determine whether it's depression with psychotic episodes, or bipolar with a psychotic episode, or whether it becomes another schizophrenia related disorder. So let's start by looking at hallucinations and delusions, which tend to be some of the hallmark symptoms of schizophrenia. The types of delusions people may experience can vary. And so when you have delusional thinking, it is a break from reality. They tend to be very fixed and rigid beliefs. There's no convincing them of, a logical reality. And they can be motivated or inspired based upon your background. For instance, my grandmother was in fact diagnosed with schizophrenia. And so my entire childhood, I understood my grandmother's mental illness. She was a very devout Christian, and a lot of her delusional thinking was centered around religion. My dad as well. My dad was diagnosed with schizoaffective disorder, which is kind of this combination of bipolar with schizophrenia symptoms in particularly his manic states. And during those manic states when he had delusional thinking, his delusional thinking was centered around religion. He thought of himself as being different people in the Bible and having different spiritual powers. And so his background, being raised in a very religious home by my grandmother, influenced his delusions, right? So your background, whether it's your culture, your family, you're not likely going to have someone who's raised as a Muslim who thinks of themselves as Jesus Christ in their delusional states, right? That type of religious delusion on my father's part was based on how he was reared in a Christian-based religious household. So there are different types of delusions that one might experience. They can experience more than one type of delusion. The first is delusions of grandeur, where they might believe that they are more powerful. My dad really did believe he was Jesus Christ at certain points. And so people might view themselves as being in greater importance and having exceptional skills and maybe even superpowers, or believe themselves to be critically important, in my dad's case, a savior, right? There's also delusions of control, where they feel like someone is controlling their brain and their thoughts. They might be suspicious of things like fire alarms, because they might look at those as mechanisms of control. And so sometimes this type of delusion can be mixed with some paranoia as well. They can also have this delusion of thought broadcasting, where they think that everybody can see their minds, almost like their brains and thoughts are on stage, and everyone knows what they're thinking. And that can also elicit some paranoia, right? Because you don't have a sense of privacy and a sense of control over what is being shared. There's also delusions of persecution, where they might feel someone's after them, someone's out to get them. And they might feel like, I remember my brother, I'll never forget this. My brother had a psychotic break. And there was a flock of crows flying over us, and he really thought that the CIA was using those crows to monitor and record his behavior, and track him wherever he went. And so whenever he saw a crow, it triggered a paranoia. Delusions of reference, where they think that things are referring to them or referencing them when they're really not. So this might kind of make them overly sensitive, thinking that everything is about them. Like someone on stage may say something and they think that it was a direct comment to them, or maybe they have a gesture and they think it was a direct message to them when it may not have been. or delusions of thought withdrawal, where they feel like someone may have actually removed their memories, erased their memories. Sometimes they might, feel like maybe they've been taken into or kidnapped by aliens and they erased their memories type thing. Okay, let's talk about hallucinations. So hallucinations really affect all your different senses. Now, not everybody has a hallucination that affects all their senses, but in general, hallucinations are misperceptions of sensory experience. So they might have a perception but no external stimuli to warrant that. Like they might have a sensation of burning, but there is no source, no fever, no external heat source that might actually be contributing to that sensation. They might hear the voices, but there's no one there that's talking. There's no speaking that's happening. No videos, no music, no sound, but they're actually hearing that voice. And so it taps into their senses. About 50% of patients report auditory, so they report hearing voices. So about 50% of those experiencing some sort of schizophrenia spectrum disorder have auditory hallucinations. 15% have visual. That may be included in the 50% that have auditory. It's not one or the other. Sometimes they can have a combination. And about 5% report tactile. And we don't have the statistics on olfactory, which is smell, or gustatory, which is the taste. But they can also experience perceptions of smells or tastes that aren't really triggered by any external stimuli. So when I say single or multimodality, I mean they can experience one hallucination impacting one sense, or they can experience multiple hallucinations that impact different senses. Even though there isn't an external stimuli, the experience of that sensation is very much clear and definite and real to them. And so the fear is real. The impact and effect of those sensory experiences is very much real to them. When we talk about auditory auditory hallucinations, because the majority of those with these symptoms have auditory, we've been able to collect a fair amount of data on them, and they often hear voices in their heads. And those voices can be mean, they can be cruel, they can be directive and commanding them to do things. They're often unpleasant and malicious and mean. They can often be directed at the person, where the voices are saying mean things about them, to them, and they can direct them to do mean things to themselves sometimes, or even others. And so it can be very frightening. I also want us to empathize a little bit, because we all have our own mind. We all have our own inner critic, and sometimes we're our worst critic. And we can even engage in a conversation with ourselves inside our own head, right? I'm like, Ajana, how can you be so stupid? Why would you say such a thing? How insensitive and rude, right? And I can beat myself up and imagine that like 100 times exponentially worse, and then multiple voices coming into play. Sometimes if we can position ourselves from a state of compassion, where we can understand, this is a normal experience that all humans have, where we have this inner critic, but the hallucination, the auditory hallucination, is an exaggerated form of that inner critic, those internalized voices that can really take a hold of our emotions and our thoughts in some very scary and disruptive ways. So another type of symptom clinical presentation we have to be mindful of is disorganized thinking, which is most notable through our speech patterns, right? So you might have just kind of off the wall conversation thoughts coming out. People might be talking about stuff that may seem completely unrelated, has nothing to do with anything. And they get stuck in these very concrete, rigid thought patterns where they're fixated on one thing in particular, and they might seem obsessive about that thing. And you can try to talk to them about, it's not making sense, this isn't logical, it's not relevant. You can try to talk them through it, but it doesn't matter. They're kind of disconnected and they don't have any insight that this is really their illness that's producing this fixation or this illogical thinking. And so unfortunately, when they have this disorganized thinking, it makes them really resistant to treatment because they're not able to kind of separate themselves and recognize that these are voices inside my head, or these thoughts aren't logical or reasonable. And so it becomes a little bit challenging to kind of help ground them and find the logic. So we can't read people's minds. So how we get insight into the disorganized thoughts is through their language. And often they're very incoherent in what they're saying. It's sometimes referred to as word salad. Think about someone that may have suffered some sort of head trauma and they've had brain injury, and they're not able to speak in a coherent way. That's what this may actually seem like. In fact, some suggest that this should be really treated as a neurological disorder rather than a psychological or psychiatric disorder. But that incomprehensible, that illogical, tangential, the disorganized speech can be very prominent. And then they also have derailment, where we might think 1 + 2 = 3, and it seems our conversations and our thoughts can progress in a logical way. And for somebody that's experiencing derailment, there isn't a logical progression or connection. We may not understand. Sometimes you have conversations, just everyday conversations, where in your mind it triggers something else, and so you move the conversation to something else and you think, oh, I've gotten off topic. But there was some logical connection for you on why you went off course. For individuals experiencing derailment, there is not that logical progression. It's almost like the thoughts jump and they don't necessarily have a logical bridge that connects the thoughts from one to the other. So they might seem like the conversations are bizarre in nature. And they might also have bizarre motor behavior or movement, right? They might kind of look like they're going through a regression, and they might have childlike behavior, and they might become agitated and irritated with no apparent cause or stimuli. They might experience catatonia, which is a reduction or maybe even the absence of any kind of response. So in my brother's case, when he had his psychotic break, he was in the mental hospital and he literally was like a frozen statue. There was no movement, there was no engagement, there was no eye contact. He literally sat in a chair. He even fell forward and he was just drooling. We had to strap him into the chair, and he was like that for some time. It took a little bit of time to pull him out of that catatonic state. So there's different types of catatonic behaviors. Again, an individual can be impacted by one or more of these. Negativism is when it seems to have there's absolute negative understanding or zero understanding. So they don't take instruction. If you asked my brother to help him, get into bed or to move or to try to feed him, you couldn't offer instruction like open your mouth. It's just not something that he could do in that time. You might have mutism or stupor, as they've called it, or they're not engaging in any kind of dialogue. That conversation's just absent. Rigidity, where their body posture is rigid, statue-like. They're resistant to being moved. Posturing, where they might hold an odd, awkward position for extended periods of time. Sometimes with posturing, you can even move them in a different position and they'll hold that for a long period of time. And even excitement, where they have this hyperactivity for maybe it's, a hand movement like this for a long period of time. They also might engage in staring, grimacing, or echoing, where you might see something and they echo it again and again and again. And so all of this is engaging in kind of motor behavior that clearly is disorganized, sometimes unpredictable, sometimes quite startling because you don't understand it. So those are positive symptoms. The catatonia can sometimes be a negative symptom, right? But the inability, so negative symptoms are a decrease, a reduction. Maybe it's speech, maybe it's pleasure, emotions. We'll talk about anhedonia in just a little bit. But what happens is you start to see things slip away often before you start to see those positive symptoms. So I really need you to move away this concept of positive and negative being good and bad. It's really the added presence of more dysfunctional type symptoms, or the removal of what would normally be functional thoughts or behaviors or speech, let's say. So negative symptoms, you start to see things slip away. Like they might be disengaged, they might not be expressing joy or happiness or emotions, they might not be engaging in conversation, their movements may decrease before you start to see some of the positive symptoms like hallucinations, delusions, disorganized thoughts. Sadly, negative symptoms have a poor prognosis. So the more negative symptoms they have and the more they show kind of that removal and disconnection, the greater the severity of the condition and the disorder, and the less likely they are to recover. You can take some antipsychotic medications, which are typically really good at helping address the hallucinations, even the delusional thinking, but sadly they're not as effective at treating the negative symptoms. And so it could be that we just haven't found the right medication and how to engage that, and maybe neuroscience down the road will produce that for us. But for now, and that could be why we have such a negative prognosis, because we really haven't found an effective way to treat negative symptoms. Some of the main types of negative symptoms that we see is we see a reduction or absence of emotional expression. So they may not even express happiness, joy, even sadness. They can almost feel like they're completely disconnected. Ologia is the absence of speech. Poverty or reduction or absence of speech. Anhedonia is inability to experience pleasure and joy, even in things that otherwise do produce joy for them, maybe a particular food or a TV show or even a person. They may not react to or show that same response. I think that's actually asociality. So they're not really interested in engaging in social relationships. They're not showing any connection to other people, even people that they love and they find comfort in. My brother didn't respond to me when he was in the psychiatric ward. Abolition or a lack of motivation in goal-directed behavior, something as simple as dressing themselves, even their own, bathing or going to the bathroom. And so they actually may need a caretaker when they're in the peak of a psychiatric break. So these can be really distressing at times. For me, it was particularly hard to see my brother. It was almost like he was gone, even though his body was there. So let's talk about some of the different diagnoses. You can have a brief psychotic disorder, right? And that was my brother's case, where he went into this psychotic state, but he didn't stay in that state. He came out of it. And when he came out of it, he was released from the hospital, and he went back to what would seemingly be a normal life for him. You can have schizophreniform disorder, where you have schizophrenia, any of the symptoms that we've described, the clinical presentation, but they're only present for a month. They're present for at least a month, but no more than 6 months. Once it hits a 6-month marker, it really progresses from a schizophreniform disorder to schizophrenia. So schizophrenia is when the symptoms have been present for at least 6 months. Schizoaffective disorder, as I mentioned with my biological father, is a mood disorder. So affective, remember, in psychology, is emotional expression, affect. And schizoaffective disorder is the combination of schizophrenia symptoms with mood disorders. Typically, it's often coupled with bipolar disorder, but it also can be, you can have psychotic symptoms associated with depression as well. So when you're talking about schizophrenia, we say it's heterogeneous in terms of the clinical presentation because the symptoms are not the same. Every client's different and unique. You might have 5 clients and they have a complete different clinical presentation for all 5 clients. The diagnostic criteria requires that they have at least 2 of the following, so delusions, hallucinations, disorganized speech. Impairment, those symptoms now prevent them from living their lives, whether it's professional, whether it's personal, whether it's academic, but they cannot engage in their regular routines. And when they continue to be disturbed and distressed emotionally based on these symptoms for at least 6 months. So they not only are going to have the clinical symptoms that we've discussed, but they're not going to be able to function in their everyday lives, and they're going to continue to experience that emotional distress for 6 months or longer. Now, these symptoms can be what we call prodromal or residual. So you might have some symptoms that appear before we actually meet the diagnostic criteria. So it could be building or leading up to a diagnosis, almost like a cold, where you start out maybe with a scratchy throat, and then it progresses and you have full-blown symptoms. Same thing with schizophrenia. You have some prodromal symptoms, some precursors, and then the symptoms progress until you meet the full diagnostic criteria. You can also have residual symptoms where you meet the diagnostic criteria, you go into treatment, you're prescribed psychotropic medication, antipsychotic drugs, you're going into therapy, you have some psychoeducation, you have some family support education resources, you are entering into therapy as well, and you're learning to recognize your symptoms, and maybe you progress. And now you progress to the point where you no longer meet the diagnostic criteria, but you have some residual, you have some leftover. Kind of like as you're healing from a cold, maybe you have a leftover cough that continues to linger for a little bit. Our throat's better, our head's better, but our lungs need a little bit more time to heal. Those are residual symptoms. I also want you to be mindful that you have mood symptoms that commonly occur with schizophrenia, some depression, and maybe some mania, even after depression alleviates or the mania alleviates, the psychotic symptoms remain. Whereas when you have like a mood disorder with psychotic symptoms, that's different, where often the psychotic symptoms subside when the mood symptoms subside. With schizophrenia that has mood circumstances, the psychotic symptoms typically remain even after the mood symptoms improve. So when you talk about schizophreniform, which is the precursor, right? Longer than a month, so a month to somewhere between a month and 6 months, the symptoms are there. Now, quite often, diagnosis of schizophreniform is a strong predictor that you will likely meet a diagnosis of schizophrenia at some point. So about 2/3 of the people who have schizophreniform disorder move on to be diagnosed. Those symptoms persist for 6 months or more, such that they now can meet a schizophrenia diagnosis. And only about 1/3 subside after that, somewhere between the 1 and 6 months they get better. So a psychotic break is less than a month. Between 1 and 6 months, it's schizophrenia. Once you hit 6 months or longer, let me go back. Less than a month, you can have a psychotic break, right? A psychotic episode. Schizophreniform is between 1 and 6 months, longer than 1, less than 6. And then 6 months and longer is schizophrenia, okay? You don't have to be fully impaired, right? And also it can't be a mood disorder with so there's kind of this eliminating criteria in terms of the length of time for other schizophrenia diagnoses. You also have to kind of eliminate that it's a mood disorder. So it can't just be associated with the mood. And now schizoaffective disorder is in fact intertwined with mood disorders. So not only do you have the clinical presentation of the psychotic symptoms that we've described, you also simultaneously have your major mood episode, whether it's depression or mania. For my father, his psychotic breaks were associated with his manic states. For some, they're associated with the depressive states. For some, they might experience psychotic breaks in both. Sometimes those the symptoms that they experience in those psychotic episodes are different, whether they're in a depressed mood or whether they're in a manic state. For my dad, they seem to be really consistently centered around religious delusional thinking. His girlfriend actually, she would actually kind of run naked through the neighborhood. She'd strip down her clothes. And so that was always a clear indication that maybe we need to get her to her psychiatrist and adjust her medications. So, again, you have to have the depressed or manic episode, and then you have the psychotic. In order to meet this diagnostic criteria, the psychotic symptoms they carry on for about 2 weeks after the episodes pass. So after the mood episodes pass, you still have these psychotic symptoms, which again is what differentiates it from a mood disorder with psychotic symptoms. Now this is a psychotic, a schizophrenia spectrum disorder with mood elements as well. And so there is that differentiation between the two. So another related disorder is delusional disorder, where you don't have the other clinical symptoms associated with schizophrenia, like the hallucinations or the disorganized speech or thoughts or the catatonic behavior. But this is related purely kind of to the delusional thinking. And the delusional thinking is interfering with your ability to just live your everyday life. Sometimes it can coincide with some depression or mania states. But there's 5 main types or subtypes, or what we want to call modifiers in the DSM when we're diagnosing. Erotomanic delusion, where you might, think that someone is in love with you, and maybe you think they're obsessed with you, and that's how you interpret everything through this lens. Eroto, meaning kind of drawn to, right? Sexually drawn to or aroused. Grandiose delusions, where you think that, there's something wonderful and special about you. You have some sort of special talent, insight. Again, they can be religious in nature, where you think you're a savior or a superhero of some sorts. A jealous delusion, where you think your partner might be cheating on you, and you're drawing kind of false conclusions, right? This isn't like someone that's been cheated on, and so they think that their partner's being unfaithful again, and maybe, they're jealous for a just cause. No, this is completely illogical, it doesn't make sense that they're drawing those speculations. And persecutory delusion, where you think you're being persecuted, targeted, spied on, conspired against. It's not uncommon. I've seen them think the CIA is after them, but because of this kind of fear-based, where you think people are out to get you, this is actually where you're at greater risk of being hostile, being aggressive, being resistant to people, because you don't trust anybody, right? So you may not feel safe, and so you may feel the need to protect yourself or defend yourself. So it's not uncommon people who have this type of delusion, the police might be called on them, and we have to be careful that these situations aren't being escalated into police brutality, or sadly even being killed at the hands of police. And this is why maybe social workers involved in the judicial system, or therapists, clinical forensic psychologists involved in the judicial system can be helpful. Somatic delusions are where they report somatic meaning body, right? They have bodily functions or abnormal sensations. And so there can be other modifiers where they have mixed, where they have multiple delusions, and unspecified, where they might have other delusional thinking that doesn't relate to any of those that have a clear category or diagnosis that's dominant, right? And then a bizarre type, where they actually are just completely kind of disconnected, and it might seem like it's coming from what might be perceived as normal and ordinary, but it's just not logical, and it's not understandable to their therapist or otherwise. So let's talk about the prevalence rates. When you're talking about schizophrenia, you're talking about less than, that should say 0.3. It's less than 1% of the population. So it is rare. We don't see significant gender differences. Men and women is equally likely to develop schizophrenia. How it manifests might be different. Men show more negative symptoms, which sadly means a worse prognosis, and women might have more emotional expressive symptoms. Where you're at greatest risk is kind of early adulthood, late adolescence, early adulthood. This is a fear that I continued. I'm 52. I haven't shown any signs, so I'm quite likely not going to demonstrate any symptoms at this stage of the game. But young men can actually manifest symptoms earlier in their life. My brother was 23 when he took his life, and he was in his early 20s when he started to show some symptoms. His were also drug-induced, which we'll talk about. And you might actually, have that slow, gradual prodromal symptoms that I talked about that progress over time. Sadly, the prognosis or the long-term probability of getting better is worse when you had younger age that you were diagnosed, negative symptoms, and sadly, prognosis is not great overall. We have less than 15% of those diagnosed with schizophrenia actually ever fully recover. This tends to be something that requires lifelong care and treatment. Schizoaffective disorders, schizophreniform, and delusional disorder also have significantly lower, they're also less than 1% of the population. But we do see a higher rate of diagnosis of schizoaffective disorder among women. So we do start to see a gender difference. Now keep in mind, when we went over mood disorders, there's also a higher rate of women being diagnosed with depression. And so the same gender difference in schizoaffective disorder can be traced back to that gender difference as well. In terms of co-occurring disorders, substance abuse disorder, 100% increases your risk, particularly marijuana. And when you have a genetic predisposition to schizophrenia, the drugs can be even a more prominent trigger and factor, which I think was the case for my brother. We had the history of schizophrenia with my grandmother and my dad. And then we also had a history of substance abuse with my dad, who was an alcoholic. And so I think we definitely had a genetic predisposition. And so my brother's drug use may very well have been a factor. Anxiety-related disorders, particularly OCD and panic disorder, are associated with schizophrenia, particularly as they might relate to some of the paranoia and some of those delusions where, they're grounded in a lot of fear, a lack of trust, feeling kind of very vulnerable and insecure. Schizotypal and paranoid personality disorder, those when you start to demonstrate those personality disorders, they might be indicative that a schizophrenia diagnosis or one of the diagnoses might be soon to follow. And then we also have to be mindful that individuals experiencing any of these disorders might be at greater risk of taking their own lives. About 5 to 6% of them die by suicide, and about 20% of them attempt suicide. So monitoring them, making sure they're safe, is critically important. And that requires better health care than what's currently available, and family engagement and involvement as well. Other symptoms that might also be present: weight gain, diabetes, metabolic syndrome. Again, more evidence to suggest that there's more neurological basis involved, things that impact the neurotransmitter levels, dopamine levels. Also cardiovascular and pulmonary disease, which again also impacts your brain in terms of oxygen and heart rates. Some schizoaffective comorbidities, again substance use and anxiety. And then we don't know about the others with delusional disorder and or schizotypal disorders. When you talk about what are the underlying causes, we definitely think there's a genetic component. When we're talking about twin studies and we compare differences between identical twins and fraternal twins, or monozygotic, where they came from the same egg and share 100% of the same genetics or DNA, as opposed to dizygotic or fraternal, where they came from different eggs and they don't have 100% of the same DNA. They have the same prenatal environment, but not the same DNA. We actually have a significantly higher rate of co-occurrence. So when one identical twin is diagnosed, there's a 48% chance the other will be diagnosed as well. When a fraternal twin is diagnosed, the chance is only 17%, which is still higher than a typical twin. Not a typical twin, a typical sibling. So there is some environmental, right? They have a shared prenatal environment as fraternal twins, which may account for the higher rate. And prenatal environment has been shown to be related, including like being exposed to flu, high stress environments. When you're pregnant, it increases the risk. But it could be that they also share, twins share a greater risk of sharing the same brain abnormalities. If you actually click on this picture, it'll take you to a news story about these particular twins who are both suffering from schizophrenia. They're actually living on the streets of New York. They're both homeless, which is not uncommon. As we know, a good chunk of our homeless population does suffer from mental illness. Schizophrenia in particular can put you at great risk because the family may be completely at a loss on how to care for you. They might even be afraid. And often sadly, our healthcare systems, even our community-based health systems, aren't really great at having, good, healthy, and accessible care. Sadly, there's not enough care available for the people who need it. Neurobiological issues as well. Over here, you're seeing some brains. This left brain is a non-diagnosed brain, and the right brain is actually a schizophrenic brain, where you see more actual cortical brain volume. You actually see more brain tissue and less over here. Notice it's not as dense and packed. These spaces right here are your ventricles. There's actually cerebral fluid in those ventricles. And you see the ventricles are much larger in the brain with schizophrenia diagnosis. So they do feel like that is a contributing factor. Specifically, the medial temporal lobe is most significantly impacted, which also houses, underlying that is the amygdala, the hippocampus, and the neocortical surface of the temporal lobes, all of which might be related to the auditory hallucinations and just processing auditory information. So it might contribute to that disorganized thinking and that disorganized speech, because they may not be processing that information in a normal, adaptive, healthy way. They also have smaller orbital frontal regions, which aren't visible in this particular side of the brain. Here's what you're seeing is the back side of the brain. And so the front side of the brain is where you're going to see this region, which is associated with inhibition, where we can kind of control our thoughts, our movements, our actions, our speech more effectively, and that might be impaired. In terms of kind of environmental factors that might be related, there's this notion of the stress cascade. So the stress actually triggers a cascade of neurotransmitters internally. So this is an interaction between our environment and our biology. We might even have a genetic predisposition, and then we have these stressful life events, and then that further changes kind of our internal environment. It activates the HPA axis. So if you've studied stress in an intro-psych class, we talk about hypothalamus, pituitary, and adrenal glands, and that activation, how the hypothalamus activates the pituitary gland, which then activates the adrenal glands, and they release these corticotropin releasing hormones. The pituitary gland releases the corticotropin releasing hormone and the adrenocorticotropic hormone, and then the actual adrenal glands release the glucocorticoids or the cortisol. And that extra flow of cortisol, it's great when you're in an emergency situation, and it prepares you for fight or flight so you can respond to that stressor, that trigger. But unfortunately, when your brain already has some abnormal structures, this might actually trigger the psychosis and might alter your normal brain functioning. And then it also activates dopamine levels. And the dopamine hypothesis, although research is suggesting that dopamine hypothesis alone is probably not a great explanation for schizophrenia, that there's likely other neurotransmitters involved. But when you have excess levels, it can be problematic, and lower levels can be problematic as well. And so more research to come. Here's a list of different neurotransmitters and what research is showing in terms of how they're impacting positive, negative, and some of the cognitive symptoms associated with schizophrenia. We also have this diathesis stress model, which actually talks about how stress might activate the psychological disorder within us. So we have some sort of impairment, and then we have this environmental, so biologically we have this impairment, this risk. Then we have these negative life events that are very stressful. It creates these dysfunctional attitudes, not just the internal environment we just talked about, but also now these attitudes, these negative ways of interpreting the world and cognitively understanding the world, which might hyperactivate that HPA axis and then now activate a schizophrenia diagnosis and the symptoms. And so the stress creates this risk within us where we now are more prone to these dysfunctional thoughts and interpretations, and contribute to that illogical thinking and the delusional thinking. And now we have those maladaptive symptoms and behaviors. Other things is our family environment matters. So when you have families that have high emotional expression, hostility, conflict, criticism, negativity, like when you have been around families that are just like overwhelming, like it sucks the life out of you because the emotional levels are so high and so intense, that's actually a really strong predictor of schizophrenia. Or when you have very dysfunctional families where they're enmeshed in one another's lives and maybe constantly blaming or fighting high degrees of conflict or jealousy, these kind of catty relationships, that actually is a strong predictor of schizophrenia. So even when we pull people out of those environments, we treat them, when we put them right back in, it actually increases their risk of the disorder returning. In fact, they're twice as likely to relapse when they return to those types of negative family environments. So good comprehensive treatment should address the family as well, not just the client or the patient, but the family as well. And when there's high conflict families and when we're returning them into a home environment that's high conflict, that may not be best for their outcome and their prognosis. So if they've done really well in treatment, we might want to consider alternative living arrangements for them. So overall, good, healthy treatment, comprehensive treatment, almost always involves some sort of psychopharmacological treatment or psychotropic medication. They're typically prescribed an antipsychotic medication, but they should also be wrapped with really great therapy. Both group and individual therapy have proven to be helpful. And then also those family interventions. So maybe a family therapy, maybe family education, maybe a social worker actually going into the home and observing the family and giving them resources and tools to help alleviate the conflict and create healthier emotional and communication skills. And then it's really unlikely that they'll ever return to the same behavior and performance and functioning as before the diagnosis. And so we often see that this particular diagnosis, this set of disorders, often requires some degree of lifetime care and intervention. But you can continue to support people. Empathy, compassion, kindness, actively listening to them. Don't invalidate them. Treat them like a human being with love and compassion. Give them a fair degree of acceptance and support. It can be valuable, even when they're in the peak of their psychotic break. Offer them love, support, and compassion. Try not to take things personally. Don't internalize them if they're experiencing some of those paranoid delusions, right? Or if they're experiencing some of the jealousy. Make sure that you recognize it's the disorder talking and not them personally. And that's helpful for your own well-being. And it's helpful to get your own therapy, right? And to find a support system for you so that you can be encouraged and supported as well. Antipsychotics are really important. There's conventional ones, but these tend to have more risky side effects, and sometimes the side effects can be more disabling than the actual symptoms themselves, depending upon the person. So working with a psychiatrist, monitoring the symptoms closely is really important. The tardive dyskinesia can be really challenging. That's where you have involuntary movements in the tongue, mouth, and face. You might see what appears to be tics. The atypical drugs typically don't have the same severity of symptoms, but they can have some side effects as well. Although they are designed to manage positive and negative, they tend to be more effective at managing the positive symptoms. Sadly, there's not a lot of compliance with medication for schizophrenia because of the side effects. And that's why we end up seeing untreated schizophrenia quite often. We still have much research and work to be done in terms of finding effective medication and intervention. Cognitive behavioral therapy is often important and helpful. We definitely want to get into people's cultural, familial backgrounds that might help us understand maybe some biases and attributions that might be contributing to some of that delusional thinking. We want to help them manage a more effective and healthier emotional and behavioral response. We also want to help them find healthier and adaptive ways to interpret and understand their symptomology. So psychoeducation is an important part of any therapy program, but in this case, we're going to educate them about the disease, the symptoms. We're going to help them recognize and identify the symptoms when they're experiencing them, maybe teach them ways to combat them, and to kind of address those negative thoughts and behaviors and maybe even replace them with positive ones, reframe, teach them positive coping strategies and ways that they might be able to distract their mind and pull themselves out of a delusional episode. I have seen, there was an individual that I went to a NAMI presentation. They have this program called In Your Own Voice, or In Their Own Voice, and it's them sharing their own stories. And I did actually meet an individual who does manage their schizophrenia fully without any kind of medication. It's rare, but it is possible. NAMI, National Alliance for Mental Illness, may be a good resource for you. We want to focus therapy on trying to preserve their independence, helping them manage their self-care, their work and school commitments, securing employment that might be a good fit for them and supportive of their diagnosis and condition. And we want to make sure that we're giving them the skills necessary to have healthy social relationships. Social support is a really strong predictor of successful outcomes in schizophrenia and most mental health circumstances. We might have them in group therapy, which can be a really good resource for social support, and they can do role playing, they can get some validation, we can actually go and engage in kind of field trips and do community outings, and help to address kind of any negative thoughts they might be experiencing or symptoms they might be experiencing in the moment, and be a resource and support for one another. And then additionally, the family interventions. So we want to make sure that we're creating a healthy and adaptive environment as best as possible that reduces and minimizes the stress for the individual that might be triggered to have those psychotic symptoms. And we want to make sure and it's going to benefit everybody, not just the patient, but also the family as well, right? They also will be taught about the disorder and the clinical presentation of symptoms, how they can identify the symptoms as well, and good, healthy responses, how they can intervene in a supportive, loving, healthy, adaptive way for the client and for one another. And we're going to teach them healthier problem solving, communication skills, how they can really improve their relationships with family members, and how they can cope with the different stressors in their life in a way that allows them to resolve conflict in healthy, productive ways. And that might involve family therapy and helping to provide some healing and restoration for challenged and strained relationships. And then finally, we're going to address social skills training overall, where we're going to teach them better communication, better interpersonal skills. Those might be things that they didn't even learn before they had the disorder, right? So we want to teach them how to maintain healthy relationships, communications, boundaries, actually like goal setting in the relationship, finding balance in the relationship where there's a reciprocity and there's shared responsibility and shared communication, and where I'm taking responsibility for expressing my needs in a healthy, adaptive way, and they're taking responsibility for expressing their needs, where we're communicating effectively and we're making eye contact and we're doing an exchange. It's not all about one person taking responsibility or communicating, but we're having this exchange in our conversations, in our support, in our resource, and our responsibility. That might involve role play, but even in family therapy, it might involve role play within the context of group therapy. It might involve family therapy as a group or individual, what we call conjoint family therapy, where I have sessions with different combinations of family members. But ultimately, we're going to, whoever the social resources are within that person's lives, we're going to try to teach you how to engage them in a healthier, more adaptive and effective way. And when outpatient mechanisms don't work, we might need inpatient hospitalization. Often when someone is in fact experiencing psychotic symptoms and any one of the schizophrenia spectrum disorders, they actually might need to be hospitalized so that they can be stabilized with the medications. We can control those psychotic episodes, hallucinations and delusions in particular, and then we can transition them out. Partial hospitalizations seem to work really well, when they go in for the day. They have a full day program in the hospital, but then they're released. Again, this is assuming they're being released to a healthy, supportive, functional family environment. Otherwise, the partial hospitalization may be counterproductive, right? In the hospital, they're not only getting the medication management, the stabilization, but they are also being exposed to therapy, some activities, and they will be getting some of the psychoeducation and social skills training. Sadly, I've seen our public psychiatric care firsthand, and sadly, it doesn't have the best resources. And so for me, I found it to be in many ways abusive and unhealthy and toxic. And so it's very triggering for me, the idea of inpatient psychiatric care. But, private hospitals, smaller hospitals, are more likely to provide a lower doctor and nurse to patient ratio, so you can get more personalized care. The best thing you can do is visit your loved one. Don't just put them in the hospital and leave them. One of the greatest predictors of or protective factors for making sure they're getting healthy care and patient care is family visits at random times, unpredictable family visits showing up at different times on different days. That ensures that they're going to get the best care possible. Being an advocate for them, being a resource for them, helping them know that they're not alone and they haven't been abandoned is really important for them. So, be there as much as you can. And I'll leave you with these quotes. Schizophrenia is one of the most misunderstood diseases on earth. It's a physical brain disease, no different than Alzheimer's or Parkinson's and a stroke, but it is more treatable. So we need to remove the stigma. We need to break it down. We need to stop writing people off as crazy and then turning them into the system. We need to continue to offer love, support, and engagement. Here's another one. I have schizophrenia. I am not schizophrenia. I'm not my mental illness. My illness is a part of me. Please know, schizophrenia does not define the whole person. They're still the person you love, you cherish. They still need your support, your engagement, your involvement, your compassion, and your support. Much love and aloha to all.